let's continue. Now, what I thought about last time was that there's several times where you'll see literature written that hypothyroidism and hypocalcemia and hypercalcemia both cause a drop in muscle contractility. Okay? And the question you have to ask yourself is, you can memorize it, or I can give you an explanation to make it more sense. Okay? We've already studied before, and this is why it's clinical important, why we do all this stuff. First thing we talked about in the last 2 or 3 weeks is that we've been talking about receptors. Okay? The neuromuscular junction requires the release of acetylcholine, which then binds to the receptor, which then causes sodium to come in, which then causes a spike in electrical pattern, which then causes the sarcoplasmic reticulum to release calcium, as well as another voltage gate, okay, to open, which also releases calcium into the cell. And that increases the contraction. That's the main mechanism, right? So let's talk about first, how does hypocalcemia induce somebody to be weak? And it's simply that if you don't have enough calcium out here, if this becomes depleted, then this intake of calcium will not go through adequately, and the person will appear to be weak. So hypocalcemia is rather easy to explain because the ionized levels in your bloodstream in the area surrounding the neuromuscular junction has very low calcium levels, and as a consequence the muscle cannot contract properly. Okay, simply it's a lack of a calcium intracellularly. Okay? Now the more difficult explanation is what happens with elevations in calcium. Okay? One of the things that we teach you about is that you can give calcium in conditions like hyperkalemia, okay, to what's called membrane stabilized an individual. Okay? And what they basically mean by that is that you can inhibit muscle contraction of depolarization and activation of ventricular muscle cells. So in essence, you hopefully prevent the person from going into VTAC or VFib. Okay? And the reason that's the case is because calcium binds to the receptor site where acetylcholine is binding at. Okay? But what it does is that it's a competitor. It competes for the acetylcholine sites. So if your calcium levels are really, really high, then even though acetylcholine is being released, it can't bind, okay, and activate the acetylcholine receptor. So in other words, you don't get depolarization. So the muscle becomes weak, okay, simply because it's not firing. Okay, so hypo and hypercalcemia are both detrimental. They both induce weakness of the muscle. Okay, now if you remember this, you'll never have to memorize it again. Otherwise, you have to memorize that hyper and hypocalcemia induces weakness in a person. Okay? Make sense? Okay. Next hormonal gland is the endocrine gland of the pancreas. The pancreas is an interesting gland because it has two functions in it. It has an endocrine as well as an exocrine gland capability. The endocrine gland is that it produces insulin and glucagon and some other ones. And it's also an exocrine gland, which is actually, it releases digestive enzymes that eventually go into what's called the pancreatic duct and eventually exits into the small intestine, okay, where it helps and aids in the breakdown of fats. Okay, so pancreatic enzymes are really important for nutritional breakdown of food. There are certain kinds of diseases that will damage the pancreas, and the exocrine function will begin to release into the surrounding tissue and cause what's called saponification. Okay? And if you enter somebody's abdomen and look into somebody's belly like that, you will literally see like soap all over inside because the person's out of digesting their own pancreas as well as surrounding retroperitoneal tissue. Okay? and that person develops a very severe form of pancreatitis as the end result. Okay. As for the endocrine function of it, it's usually made up by what's called the islets of Langerhans. The islets of Langerhans can have different nomenclature for the kinds of cells. They release different kinds of hormones, specifically glucagon and insulin. Okay? The alpha cells are actually release what's called glucagon. And glucagon is something that we use quite often in our clinical practice to cause sphincters to loosen up and to stop peristalsis from taking place. So glucagon is very important for us when we're doing endoscopies and things like that, and if we want to do things where we're working against the sphincter of Oddi, which is where the common bile duct connects up to the small intestine so it doesn't spasm on us, we gave that person glucagon. Okay? Glucagon is secreted and promoted by decreased blood glucose levels. It stimulates glycogenolysis and gluconeogenesis and lipolysis. In other words, it basically drives sugar levels up, okay? Which is basically usually in a state where you're not taking in adequate nutrition. Glucagon is usually released as a consequence to drive the sugar levels up. The danger of glucagon, of course, is that if you give it too rapidly or too big a dose, you can make somebody hyperglycemic. Okay? So you can drive their sugar levels out of control. Okay. The beta cells are on the beta islet cells of Langerhans produce insulin. Okay? And insulin is one of those very important hormones that regulates your sugar levels, your glucose levels, by driving potassium and glucose together into the cell. Okay? So when you give somebody insulin, you got to always remember that this is a synergistic pump. It's a symport system. Okay? It both pulls glucose into the cell as well as pulling potassium into the cell. So if you give somebody who is hypokalemic insulin, you're going to make them even more hypokalemic, and they can become cardiovascularly more likely to develop atrial fibrillation, atrial flutter. Okay? The other thing important knowing this is that this also helps in the treatment of hyperkalemia. And one of the things that we do is give that person glucose, insulin, and then that also helps drive potassium into the cell where that can be safely held without any problems. Insulin is produced from a molecule called proinsulin. Proinsulin is then converted into insulin itself. It's controlled by both chemical, hormonal, and neural activation mechanisms. The sympathetic nervous system tends to drive the release of insulin to be decreased, okay, and increases glucagon levels. So most people that are under surgical stimulation, they don't become hypoglycemic, they actually become hyperglycemic. Okay, so you get an activation of glucagon and inhibition of insulin. Okay? Many times under very high severe stress conditions like open heart conditions, where we actually go cutting to the sternum, that's a pretty big stimulation. We tend to put these people on insulin drips to keep their sugars under tight control. The other reason that sugar levels go out of control in the operating room for open heart surgery is that the actual pump initiating solution has high doses of steroids in it, which then drives your sugar levels very high. Okay? Secretion is promoted by increased blood glucose levels, which then drives the glucose back into the cells. It facilitates the rate of glucose uptake into the cells of the body. Okay? The downside to this, of course, is that glucose is the main precursor for nutritional value for the brain. Okay? And elevations in glucose levels, if you go into a time period where the brain should be quiet and you have high glucose levels, the brain will continue to uptake the glucose, which increases the basal metabolic rate, and the consequence increases the risk for that brain cell to die. Okay? So patients that are hyperglycemic at the time of a bad event, like a systole or a bad VTAC, VFib, where they lose perfusion to the brain, they have a much higher risk of developing brain damage. Okay? It is considered an anabolic hormone because it helps with the synthesis of proteins, lipids, and nucleic acids. The other two more cells that are responsible in the islets of Langerhans are the delta cells and the F cells. The delta cells release somatostatin and gastrin. There's kinds of tumors that actually will produce high levels of gastrin, which then produce high levels of gastric acid levels. and the person will develop ulcers as a consequence. As for somatostatin, that's involved in regulating alpha and beta cell secretions. It's like a negative feedback mechanism, sort of regulating the system. We don't quite understand completely how it works, but it is important for regulating insulin glucagon release. F cells are pancreatic polypeptides that are more complex, that again, we don't know the full function of them. Okay? What I want you to know basically is really which one is the beta cells that release insulin and the alpha cells. You really have to know that for tests. They always ask that on boards as well. Innervation of the pancreas is parasympathetic, which might kind of make sense. It's vagus nerve, most likely. The reason it makes sense is because it's part of digestion. Digestion is normally a parasympathetic activity, not a sympathetic activity. Sympathetics are also involved in the pancreas, and they inhibit basic digestion, so they're on the inverse side of it. Parasympathetic activation tends to increase pancreatic secretion of exocrine exocrine secretions, as well as increasing levels of insulin usually, because that's usually when you're beginning to feed, so you're trying to uptake your sugar into your cells. The next gland we'll talk about, and we're almost finished, is the adrenal gland. The adrenal gland is broken up into two components. The adrenal cortex composed most of the adrenal gland in weight, which accounts for about a total of 80% of the adrenal gland in weight. And what's really disappointing is if you look at the picture, most pictures sort of show this in reverse. This looks like, to me, artistically, this looks like the adrenal cortex is actually a small percentage of it. Okay, and it isn't. It's about 80% of the total volume. Okay, so this should be, it's not drawn properly is what I'm trying to tell you. Okay? The adrenal cortex should be more like down to here. Okay, so it's really a small area is the adrenal medulla. 80% of the volume of the adrenal is the adrenal cortex. Okay? It can be broken down into what's called zona glomerulosa, fasciculata, and reticularis. We're going to talk about that later on when we talk about the neurohormonal mechanisms next semester. The adrenal medulla is where the adrenergic drugs are being produced. This is epinephrine and norepinephrine. You know, if you lived in Britain, what would they call adrenaline? What would they call epinephrine? They'd call it adrenaline. Okay? Why don't we call it adrenaline in this country? But we use the word adrenergic everywhere. Because if we did, we'd have to pay them British royalties for the drug. So they got around it by saying, you know, epinephrine's an endogenous drug, so we don't have to pay you. And that's how they got around it. Okay? So all American medicine is always epinephrine and norepinephrine. If you live in Europe, it's called adrenaline. Nobody ever uses epinephrine as a wording. Okay? So it's just a difference in cost, I guess. The adrenal cortex has no innervation in it at all. Okay? So it's really a true hormonal system. Okay? What activates the adrenal cortex is things like corticotropic releasing hormone, as well as adrenocorticotropic hormone. Okay? So both the hypothalamus releases corticotropic releasing hormone, as well as the anterior pituitary hormone, ACTH, has effects. Okay? Things that will actually suppress cortical releasing hormone and adrenocorticotropic hormone will be the negative feedback mechanism of cortisol, which is usually the end byproduct in the majority of sense for the adrenal cortex. Okay? Now, cortisol, which is a glucocorticoid, okay, has significant diurnal rhythms to it. Okay, and depends on which form of sleep cycle you're in. It usually peaks at the time of awakening and it's lowest at the end of the day, so it sort of makes you feel tired and makes you want to go to sleep. Okay? You can actually fool the system, or you can really push it, and you can switch your sleep circadian cycles just by just changing that you can stay awake. And after a few days, your circadian rhythm changes. Okay? And then when you're to try to go back to normal, you have a really hard time. Okay? People that actually work on night shift will actually alter their circadian rhythm considerably, and they will fall exhausted early in the morning versus they should be waking up. Okay? So you will notice that too when you do your call schedule, that you need to deal with this problem as well. Things that will increase adrenocorticotropic hormone will be stress, okay, all sorts of stress, and as well as corticotropic releasing hormone as well. The adrenal cortex synthesizes things from cholesterol, okay, and there's 3 types of hormones that are being produced. Your glucocorticoids, your mineralocorticoids, which include aldosterone, and adrenal estrogens and androgens, okay. Even males produce a certain low-level grade of estrogen, okay. The reason that it's usually not important for males is because as the estrogen travels through the portal circulation and gets to eventually to your liver, it breaks down estrogen very rapidly, and men don't develop mammary glands under most circumstances. On the other hand, if you see somebody who develops cirrhosis, one of the things that you'll see is that that person will have enlarged mammary glands because of it. Okay, they will get gynecomastia. Okay, so that's an indication to you, if you see that in a patient, that they may have hepatic damage or hepatic disease. Okay. The other thing that you see is also that estrogen is converted from testosterone in high lipid content individuals. So people that are heavier than they should be, testosterone is converted into estrogen, which then also gives them gynecomastia as well. So it could be 2 reasons why. One is large weight mass or due to liver failure. Yes? Yes. But usually if you see this in a child and they're not heavy, you need to think immediately liver disease, some kind, Wilson's disease or something wrong with them that they have to think about why is the liver not metabolizing the estrogen. Some people are actually born with extra mammary tissue, okay, and that's just genetic, unfortunately. But a lot of men don't think that men can get breast cancer, and that's not true. The chance of men getting breast cancer is pretty low because testosterone sort of protects us from that problem, but still you can get breast cancer. Direct effects of glucocorticoids is they have direct effects on carbohydrate metabolism. That kind of makes sense if you look at the word and break it apart. Glucocorticoid, it increases blood glucose concentration, so it's an anti-inflammatory agent, which is what it's used for. It suppresses the inflammatory response and has growth-suppressing effects and influences awareness and sleep habits, increases appetites, increases erythrocyte formation, and it's the most potent naturally occurring glucocorticoid is cortisol. Mineralocorticoids, on the other hand, actually work on the mineral portion of your body, which of course is going to be sodium, which is where aldosterone tends to work. Okay? It affects the ion transport by epithelial cells and increases the activity of sodium pump in epithelial cells, specifically in the kidneys. It causes sodium retention and potassium and hydrogen loss. It's the most potent naturally occurring mineralocorticoid is aldosterone. It's regulated by the renin-angiotensin system. And aldosterone by far is the most important mineralocorticoid in this discussion. And that's something you got to make sure you separate out. Okay? When people take steroids, okay, what they're basically doing is they're mimicking this system. Okay? Now, some degree of mineralocorticoid use is used, and what these people, when they abuse this drug, is what is the other drug that they give themselves? Lasix. So a lot of times you'll see these people taking Lasix as well. You may wonder, if you see a young man taking Lasix, alarm bells should be going off in your head. Okay? And they usually get the Lasix from what? Horses. Okay, they get it from veterinarians. Okay? It's a way to make the horse be able to get lighter before a race. They used to inject the horses with Lasix and basically allow that horse to diurese and be lighter, and as a consequence, run faster. So the downside to these mineralocorticoids, of course, is that it increases the rage response in individuals. It makes people very aggressive. It also causes some other very deleterious effects on the testes. It causes a small involution of the testes and makes these people lose their ability to have children. Okay? So, and there's also significant effects on the liver. You can cause a permanent liver damage with high doses of steroids. This is something you really don't want to be doing. The next system is the renin-angiotensin system, okay, which ultimately is involved with the aldosterone. This is something you're going to have to know and memorize, okay, because it's not going to go away. By the time you're finished, this becomes an innate part of your training. By the time you get to clinical, you should be able to write this out like the back of your hand, okay? The reason this is important is this is a third system. This is a secondary system that controls blood pressure. One is sympathetics. Second is this, renin-angiotensin system. And third is vasopressin system, or the antidiuretic hormone. So the vasopressin system, the antidiuretic hormone system, regulates blood pressure by two ways. One is the angiotensin converting enzyme, the renin molecule that's produced in the kidney causes the conversion of angiotensinogen into angiotensin 1. Okay? Angiotensin 1 then gets into your venous system. Okay? As angiotensin 1 circulates into your venous system, it gets to your lungs first. Okay? And if it was activated, it would cause pulmonary hypertension, which eventually would cause long-standing right ventricular failure, which is not what you want. So the body has made a drug, well, basically made a hormone, that has no activity, which is angiotensin 1. When it gets to the lung, though, it gets converted by an enzyme that's found in the lung called angiotensin converting enzyme. Okay, angiotensin 1 converting enzyme then breaks down angiotensin 1 into angiotensin 2. And angiotensin 2, then when it gets into your peripheral circulation, is a very potent vasoconstrictor. Okay? So it helps control your blood pressure. In addition to that, it also activates aldosterone. Okay? So you can see how it comes down here. It has vasopressor effects, but it also increases aldosterone production, which increases sodium reabsorption, which then is going to increase your water intake into the kidney. And as a consequence, the person's going to retain more fluids, and the person's going to increase their total body volume. And the blood pressure should rise as a consequence. So this whole system is set up in place for stress conditions to activate renin when your kidney's not getting enough blood flow to it. So things that will cause activation of renin release will be these three things, which are in green, which is decreased renal blood flow, which kind of makes sense. Sympathetic input, of course, from high levels of stress also makes sense. Okay? The one's a little bit more difficult to understand is the stimulating variables such as nitric oxide from macula densa. The way you remember that is that cyclic AMP is a what kind of receptor from what? It's an adrenergic. It's A with A. Okay, so cyclic AMP makes sense. If you see that levels rise, it's like a sympathetic stimulation which causes increased renin release. Okay. Diuretics also, because they decrease the volume, will have that effect. Epinephrine and norepinephrine are both adrenergic agents. So they act very much like the sympathetic input. They also will increase the release of renin. Okay? Early part of the day, or even the person standing up all day, will increase their release of renin and causing increase holding of water. On the other hand, things that inhibit are on red are things like adenosine from the macula densa. Okay? Angiotensin 2, because it's a feedback mechanism, so this system feed back to inhibit. See? And that's where angiotensin 2 comes back to shut it down. You can also have adrenergic blocking agents also work at this level, so it's very, very powerful. Okay? Angiotensin blocking agents are very dangerous in the clinical. We're finding out that when we give these people that and we put them under anesthesia, we almost lose all blood pressure. Okay, so it's very, very dangerous. So we've got to tell the people ahead of time to stop it, usually a day before. There's still a lot of controversy about that, but I'm just telling you from my personal experience, it's really not something you want to see. Aldosterone is another negative feedback mechanism that suppresses the system and shuts it down. Okay? If you lay down, more blood flow comes back to your kidney flow, so that kind of makes sense. It inhibits it because of increased volume return back to the kidney. And later part of the day is because the cortisol levels begin to fall off, and as a consequence, you don't tend to retain as much fluid as a consequence. Adrenal estrogens and androgens we're almost finished with this. Okay, estrogen is secreted by the adrenal cortex. It's really minimal. Okay, it's really produced by other things, and usually in women ovaries. Okay, the adrenal cortex secretes weak androgens as well. The androgen is converted by peripheral tissue to a stronger androgen, such as testosterone. The adrenal medulla is the anatomy. It's about 20% of the total adrenal gland. It is innervated, okay, versus the adrenal cortex is not. And the innervation to the adrenal medulla is not parasympathetic. It's purely sympathetic. Purely sympathetic. Okay? This is really kind of wrong. Okay? The book is a little bit incorrect. Okay? It's pretty much all parasympathetic. It's all sympathetic. Okay? So what the cells basically do is they release high levels of norepinephrine when they become activated, as well as epinephrine. Which one's more potent? Epinephrine is more potent. Okay? Epinephrine has more of a gamut effect, of a huge effect in comparison to norepinephrine. Norepinephrine tends to affect more the actual alpha cells, tends not to affect as much on the beta cells. Chromaffin cells, which are specialized cells, which are called pheochromocytes. Okay, these are the ones that actually secrete the catecholamines, such as epinephrine and norepinephrine. And the majority that's being released is epinephrine in this area. This is one of the few areas where the major hormone is being secreted is epinephrine. And the other areas where you're looking at a neurotransmitter is norepinephrine, okay, at the sympathetic side of it. But epinephrine is what's being released here. It usually gives you the characterization of that fight and flight response. And this is where you have to memorize this for the test. Again, one more thing to give you to memorize. Okay? And there's two ways you can do it. You can memorize it, make your life hard, or you can just do it like this. Okay? If you look at it from the standpoint of how strong a medication is, you can say from the strongest to from the weakest to the strongest medication, catecholamine-wise, is dopamine, then go to norepinephrine, and then epinephrine. Okay, so the body, in essence, produces the weakest one first and produces the end product as the strongest one, which is epinephrine. Okay? So it's three ones. Okay? Now, the norepinephrine and dopamine both are inhibitors. Okay? They give a negative feedback to the rate-limiting step. Okay? And the rate-limiting step, this is where they ask all the board questions, is tyrosine hydroxylase. Okay? When you produce the hormone epinephrine and norepinephrine, the first drug that you use, the first component that you use is what's called phenylalanine. Okay? Phenylalanine gets converted into, by the liver, by phenylalanine hydroxylase, into tyrosine. Okay? Tyrosine then is a rate-limiting step. That's the enzyme that's the slowest. Okay? So if you suppress that, it has the most effect of basically not producing norepinephrine and epinephrine and dopamine. Okay? After tyrosine gets broken down, it breaks down to the first compound, which is dopa. Dopa, and then you start putting the amines to it. Okay? Which is dopamine. Okay? But the rate-limiting step in this reaction is tyrosine hydroxylase. And you have to know that because they do ask that on the exams every once in a while. And that's the rate-limiting step that comes back as a negative inhibitor and shuts down the system if you want it to be shut down. Okay. Notice that epinephrine doesn't really have a negative feedback mechanism. It's only norepinephrine and dopamine that actually have the negative inhibition step. That's the ones you shut down. You have to shut this guy down to stop releasing this stuff into your bloodstream. Because you decrease the production. Okay? The neuroendocrine response to stress, the endocrine system reacts to the nervous system to responses to stressors. The stress response also involves the immune system, which is why cortisol is so important. It's influenced by the corticotropic releasing hormone and from the hypothalamus. Things that you can use for I'm not going to go into all this detail because I think this is above your level and it's not something that you can be using every day. So don't expect any test questions on this. Just know that you do have ways of actually testing these individual hormones in your bloodstream. We can do what's called radioassay, enzyme-linked immunosorbent assay, and bioassay. So there's different ways of actually measuring levels of these different hormones. And if you're an endocrinologist, you need to learn all that, but I don't think you guys really need to at this point. Aging, this is important in Naples. If you take care of people, you got to understand that as people get older, these endocrine systems begin to break down and basically don't secrete enough hormones and they don't respond as appropriately as a person who's younger. So people that are, as they get older, the thyroid gland develops atrophy, fibrosis, and increased inflammatory nodules. Okay, that's why you tend to see thyroid tumors usually occur in the age around 50 to 60. And parathyroid glands also begin to drop off in their concentrations. As a consequence, you get inadequate calcium balance taking place. And the adrenal gland also begins to decrease the clearance of cortisol. So sometimes you won't see as much cortisol available that you want. and the person may develop what's called Addisonian's crisis as they get older, but that's still pretty rare. Okay, and that's it.